This 31-year-old patient was referred to me for endodontic retreatment of tooth number 30. According to the patient, the root canal was done about 10 years ago. And for the past few years, his dentist has been telling him that his tooth is abscessed and he's been ignoring it. Finally, according to the patient, a few days ago, his dentist reminded him again and showed him x-rays of the tooth from a few years ago and x-rayed his most recent x-rays of the tooth and showed him that these dark shadows, these periapical relucencies, were getting bigger. And this convinced patient to come see us finally for endodontic retreatment of this tooth number 30. As you can see, there's a PFM crown on the tooth, buildup and previous root canal and periapical relucency here and here. You can see the fills are short. Again, short fills, a short obturation doesn't cause endodontic failure. Leaving necrotic tissue and bacteria behind does. Okay, so if these obturations were short and no periapical relucencies were associated with the tooth and patient had no symptoms, of course, he would have been okay. But these short fills now tell us that this dentist not only filled short, but also very likely instrumented and irrigated short as well. And looking at the radiographs here, it looks like perhaps this dentist also missed a canal because I can see that the gutta-percha in the distal is not centered. And I can see a shadow here. You can see that right there. All right, so I don't need to get a CBCT. A couple of PAs for me will 99.9% of the time suffice, is enough. But if you want to get a CBCT, go ahead and get the CBCT, expose the patient to extra unnecessary radiation and charge the patient, loads of money unnecessarily, go for it. But for me, I don't do it that way. I can read x-rays. All I need to have is a couple of different angulation PAs. And again, here you can see very likely there is another canal there. All right, so we discuss options with the patient, and the patient definitely wanted, as I said, he's 31 years old. He wanted to try to save the tooth, and that's what we did a few months ago. I was going to say today, a few months ago. I'm making the video on this tooth today. I have tons of videos that I need to work on and get ready to post on YouTube. So make sure you subscribe and be ready, because many more point of view clinical videos such as this one will be posted on my YouTube channel every Wednesday morning at 6 a.m. local Pacific time here in the United States. All right, so let's go ahead and watch the point of view video from start to finish of endodontic retreatment of this tooth number 30. All right, so let's go ahead and give our IA injection, IA block. I follow the lidocaine with Marcaine. So Marcaine is going to go in next. That's Marcaine. Long lasting, gives me time to work on the patient, and also gives patient time to go home and start taking the pain medication before the numbness wears off. All right, rubber dam clamp goes on. Placing the clamp on the tooth. These black rubber dams, they're much thicker rubber dams. So they're the thickest rubber dams that they make. And they're great for retreatment cases because I use chloroform to remove the gutta percha from within the canals. And the regular rubber dam can dissolve. If there's a little bit of chloroform leaking, it can dissolve the regular rubber dam, but not this one. This one is very resilient to chloroform. So you saw it took us all 15 seconds to put the rubber dam on. As you can see, the PFM crown is pretty worn. Porcelain is missing. My assistant just wiped down the crown of the tooth, then the rubber dam and the rubber dam clamp with 70% isopropyl alcohol. And I'm going to go right through the PFM crown. You can see that that's an old, worn out PFM crown. So patient was made aware that before we start the endodontic retreatment that he would definitely need a new crown that his dentist would take care of for him once we redo the root canal for him. So I'm using a metal cutter here. Metal cutter burr to go through this PFM crown. And again, I don't use water, but I know how to use my high-speed handpiece without frying the tooth and the periodontal ligament. But for the newbies, for you guys who don't have much experience, new dentists, I highly recommend that you use water spray with your high-speed handpiece. Just going through the crown, PFM crown. Right, so I went through the PFM crown, and to remove the buildup, I switched to an end cutting cylindrical burr, which is a diamond burr. And very carefully and meticulously removing the buildup material, most of the buildup material. Once I remove most of the buildup material and refine my endo access, I will switch to an ultrasonic device to remove the remainder of the buildup material, where I can actually see what I'm doing. Here, I'm just going by the feel, removing the bulk of the buildup material and refining my endo access, as you can see. And once I did that, then I will switch to ultrasonics. All right, so I went in now, microscope, and as you can see, I have removed the bulk, the most of the buildup material, and my endo access, you can see that. And I'm gonna be switching to the ultrasonic soon. But for now, I feel like I can remove more of the bulk of the buildup material with my diamond burr. Now I switch to a thinner diamond, as you can see. And I'm just cleaning the walls and removing more of the buildup material. And my assistant, as you can see, I have two assistants. My assistant to the right is blowing air on my mirror and inside of the tooth, and my assistant to the left is suctioning. This is 6-handed endodontics. All right, and here goes the ultrasonic device, Ultramint Pro by 8 Teeth. And I believe that is a scalar tip that I'm using. You can use a scalar tip on an endo handle. As you can see, the handle is blue. So you can use a scalar tip on an endo handle. And I'm very carefully removing the buildup material, as you can see. There it goes. All right. You can see under the buildup material how wet everything is. Just take a look. Look at the color of the gutta percha. The color of the gutta percha has changed. So that tells me this dentist very likely did not use a rubber dam, and there was tons of saliva contamination during the endo treatment, the original endo treatment. You can see how wet everything is. Let's just clean everything up with our ultrasonic device. Make sure we have straight line access into each canal. And behold, right there, the missed distal buccal canal system, as you can see right there, as I had suspected. So this dentist had located the distal lingual, but had missed the distal buccal canal system, as you can see right there. I'm just picking at the gutta percha right now, trying to get a feel for everything. All right, but you saw that it took us all but a few seconds to locate that missed distal buccal canal system. You can see how wet everything is and how easily my gutta percha can get into the canals. There's just no seal. There was tons of contamination when this dentist was doing the root canal originally, as you can see. All right, so the next step is to go ahead and remove the gutta percha. And as I said, I use chloroform and a number 15. Usually I go with a number 15 C file attached to my M4 reciprocating handpiece. So I'm filling the pulp chamber. This is chloroform. I'm filling the pulp chamber with chloroform. And then I'm going to go in, as you can see, chloroform. Pulp chamber is filled with chloroform. And I'm going to use my number 15 C file attached to my M4 reciprocating handpiece. And I just pick and pick and pick at these GPs. The chloroform will dissolve them and I can basically remove them this way. Up and down, as you can see, up and down motion and a brushing motion away from the furcation. I was in the mesiobuccal. Now I'm trying to get the number 15 C file into the mesiolingual canal. Just picking at it a little bit at a time. I'm not forcing the file. The file is reciprocating, as you can see. 1000 RPM is my setting for my M4 handpiece, reciprocating handpiece, and the torque is off. I strongly recommend that if you guys start using these reciprocating handpieces, definitely practice on many extracted teeth. Your patients aren't for you to practice on them. They paid you, believing in you, believing that you know what you're doing. So don't be practicing on your patients. Practice on extracted teeth. Master the technique before you start working on your patients. All right, I removed most of the gutta percha from the mesial canals, and now I'm in the distolingual canal system, where this dentist had found the canal and obturated it. And there you go, just moving the chloroform into the canals and dissolving the chloroform this way. Adding more chloroform. And now I'm going in with a number 10 C file. Okay, number 10 C file, and I'm trying to see if I can go to my estimated working length. This buccal canal system that this dentist had missed, I can easily go to my estimated working length, as you can see. And then the distolingual canal system, also I can go to my estimated working length with this is a number 10 C file in my M4 reciprocating handpiece that I run at 1000 RPM with torque off. It not only instruments and shapes canals, but also sonically activates your solutions, whatever solutions that you have. All right, so let's go ahead and try to see if we can get a working length here using my Find PEX apex locator by 8 teeth. Yes, perfect. I got the beep. My assistant will read the measurement and tell me what the working length is. So now that I have my working length in one of the canals, the mesiolingual canal, I couldn't get patency in it. Now I know, based on the mesiobuccal canal system, what length, exact length, I need to have, very likely in the mesiolingual canal system also. So I'm using a number 12 C file attached to my reciprocating handpiece. And I'm trying to see if I can regain patency in the mesiolingual canal system. Mesiobuccal is pretty wide open, as you can see. And mesiolingual, there was a little step, little ledge, and I believe I was able to bypass it. As you can see, the 12 C file is going to my working length right now, but I'm gonna confirm it, of course. Just pay attention to how I'm using this reciprocating handpiece and the file. Just up and down, picking at the canal, not too much apical force. You don't want to create a ledge, step, or worse, perforate. That's why it's very important to practice on many extracted teeth. You know, you see how I do it, and to you, it may look very easy, but you don't realize that it's taken me years to master this technique. So don't be watching this video and then thinking that, oh, I can do this, and then go, start working on your patients right away. It's not as easy as I make it look. There you go. I'm going to my working length, and I usually, this is a 10C file, and I usually like to go about 0.5 millimeter to 1 millimeter beyond my working length in these cases, because having patency and maintaining patency throughout the endodontic retreatment is extremely important in cases such as this one where there is periapical radiolucencies. So you don't want to leave any necrotic tissue and bacteria behind. You always want to make sure that you regain patency and maintain patency throughout the endodontic treatment or retreatment in this case. All right, so I'm reconfirming my working lengths again. Let's fast forward a little bit. All right. Back with number 12 C file now again. Number 10 C file. I'm still not very happy with the mesiolingual canal. That's the canal that I'm working on right now. Remember, the mesial canals were obturated short. There was a reason that they were obturated short, because this dentist had blocked himself. All right. Not knowing the fundamentals of endodontics, had created a blockage in the apical area of the canals. So I'm trying to see if I can go through that blockage without perforating the canal. This is a number 10 C file. And you can see the motion, my handpiece, the motion of the handpiece as I'm working on this tooth. Again, I may make it look easy, but it really isn't easy. And the last thing you want to do is just watch this video and then get the impression that you can do this on your patient. You definitely need to practice on tens and tens and tens of extracted teeth. I'd say hundreds, because that's how many extracted teeth it took me to master this technique. I practiced on hundreds of extracted teeth. All right, let's see if I can get a measurement in the mesiolingual canal now. I believe I got it. I bypassed that blockage. Let's see if I can get a measurement. There you go. We have patency in the mesiolingual canal. I still need to work on it a little bit more, and that's what I'm doing right now. Remember, the path of the canal has to be a predictable path. You can't not have a predictable glide path. Your glide path from the coronal part of the canal to the apical part of the canal has to be a very smooth and predictable and reproducible glide path. You can't have a glide path sometimes and not the other times. You must have a glide path every time you put a file in the canal. Must have a very predictable and reproducible glide path. All right. So here we go, me working on the mesiolingual canal some more with a number 10C file. Looks like the working length turned out to be 21, so I'm using a 21 millimeter C file. And I still have chloroform in the pulp chamber and the canals. There you go. There you go. Now I'm going to about 22 millimeters. With that 10C file. You see my working length was, the reference for the working length was mesiobuccal cusp. So as you saw, I went beyond that. All right, so let's make sure again, reconfirm the working length. What is that saying? Measure twice, cut once. So you want to check and recheck and recheck, make sure the working length is proper, because the last thing you want to do is over instrument or perforate. All right, let's fast forward a little bit, see what we got here. All right, as you can see, I'm still working on my working length, measuring the correct working length, the proper working length. It's that important. All right, let's fast forward a little bit. All right, so here I have isopropyl alcohol, so I filled the canals with isopropyl alcohol here. All right, what isopropyl alcohol does when you have chloroform and gutta percha mixture in the canals, what addition of isopropyl does is that it makes the solution of gutta percha and chloroform kind of sticky, and it kind of binds that solution together. You need to try it on an extracted tooth to see what I'm talking about here. So that's why once I remove the bulk of the gutta percha with chloroform, I add 70% isopropyl alcohol, so I can remove the remainder of that solution, the mixture of gutta percha and chloroform better. All right, as you can see, you look how clean everything looks now. All right, so here we go. It looks like I have a number 15C file right there. So MB, mesiobuccal canal, is 20 millimeters. And mesiolingual canal is 21 millimeters. So my assistant just removed the stopper. So that makes the file a 21 millimeter file once the stopper is removed. And as you can see, I have a very nice, predictable, and reproducible glide path. And this is the distobuccal canal that this dentist had missed, and the distolingual canal. So the only canal that's 20 millimeters is the mesiobuccal canal. The rest of the canals, the other three, are 21 millimeters. Again, remember, when I use this reciprocating handpiece and I run it at 1,000 RPM, it not only instruments and shapes, but also activates the hypo or any other solution sonically. Here I'm using some isopropyl alcohol cotton pellet to remove some of the gutta percha that's kind of attached, glued kind of to the walls of the tooth, the pulp chamber walls. I can either do that, or I can also use my ultrasonics and some H2O. But take a look here, 4 canal systems. And the kind of gutta-percha and I don't know, sealer perhaps that this dentist has used, you can see that it's turned everything red. So the dentin is all red. And you also saw how much gouging this dentist had done. There was so much gouging of the pulp chamber floor. So much unnecessary dentin removal by this dentist. Okay, so now I'm using my flare file, number 20 flare file. All right, and I can literally put that to my working length in the mesiobuccal. Again, you can see I'm using it in a brushing motion away from the danger zones, and in a brushing motion, while the pulp chamber and canals are filled with 6% hypo. Again, I'm not only instrumenting and shaping with these files, I'm also sonically activating, as this handpiece is running at 1000 RPM with the torque off, this reciprocating handpiece. Constantly irrigating with 6% hypo. After each instrument, 6% hypo, copious amounts of 6% hypo. Again, pay attention to how I'm using hypo. People constantly ask me how I use hypo and how I don't get a hypo accident. Well, you need to pay attention to these videos, and you can see that I don't let the needle bind to canal walls. I don't use too much apical force on the plunger, and I'm constantly moving the needle up and down. All right, number 15 C file now. Mesiobuccal canal. Again, you can see how I'm using these files and this reciprocating handpiece. Mesiolingual, brushing motion. All right. My assistant constantly suctioning, again going in with 6% sodium hypochlorite. Copious irrigation, constant irrigation with 6% hypo. All right. These are files called Easy Shaper files. Okay. They are designed by my buddy, Dr. Kalantar, and his signature is right there. And you can purchase these files. These are great files, and you can purchase them by going to flexivodental.com, flexivodental.com, and you can purchase these files. These are great files. All right. Very good. Again, you can see how I'm using these files. And the recommended RPM is between 300 and 400. And I'm usually, when the manufacturer says 300 and 400, that means that for me, I go to 350, which is between 300 and 400. So 350 RPM. And I don't like I don't like a torque control. So, but again, that's me. I don't use torque control. But then again, I have 24 years of experience. So for those who don't have much experience, again, I highly recommend that you use torque control. And okay, well, you need to be practicing on extracted teeth first, remember. So again, you can see I went to the next file and brushing in a brushing motion. These are really great files. They're very hard to break. You really have to try to break them in the canal. Again, remember, you need to be practicing on extracted teeth. I don't know how many times I can tell you this. The last thing you want to do is just go buy these files and then without even practicing with them on many extracted teeth, just go to a patient and start using them and then break a file and say, Dr. Naziri said these files were very hard to break. They become very hard to break when you practice, when you have already practiced using them on tens of extracted teeth, so you know how they should feel in your hands. All right, so otherwise you will break them. If you break them, don't blame me. Again, going back in with 6% hypo. All right, very good. All right, so let's see what joins what. So I'm using my microsuction, and as you can see, I put the microsuction in the mesiolingual canal, and I lost volume, hypo, out of the mesiobuccal canal. So that tells me that these two canals join. Same thing happened in the distal canal. When I used the microsuction in one canal, the other canal also lost volume. So that's one way of confirming if the canals join or not. Again, going back in with 6% hypo, copiously irrigating the canals. And again, going back in with number 15C file to recapitulate and activate the 6% hypo sonically, sonic activation. So it seems like the mesiobuccal canal also turned out to be 21. So all four canals at the end turned out to be 21 millimeters in length. Because you can see here I'm using a number 15 C file, 21 millimeters. Distal buccal, distal lingual, again, recapitulating and sonically activating the hypo. All right. And my assistant is suctioning for the patient. That's why we got a little lag time. Making sure the patient is comfortable. So let me just fast forward. It looks like I'm going to irrigate again with 6% hypo. As you can see, I think right now I've used about 24 cc's of hypo total right now. All right, going back in with the next file. All right, so take a look here. All right, I'm done with my instrumentation and shaping of the canals. So let's go ahead and make our own custom-made master gutta-percha points. Here I'm using a number 25, 5%, and up and down motion of the gutta-percha is another way of activating the hypo. All right, so I'm measuring to see what my work, what the gutta-percha is to the reference point. If it's too long, then I cut accordingly. I cut the apical part of the gutta-percha that is too long, cut that, and that's how I make my own master gutta-percha cones for each canal. Each canal gets its own custom-made gutta-percha cones. All right. Okay. Microsuction. A little bit of air, just a little tiny amount of air, not too much. And I'm using a Stropco attachment, which reduces the pressure, the force of the air a lot, because the last thing you want to do is a subcutaneous emphysema. Very painful for the patient. So the last irrigation that I fast forwarded. My last irrigation was 70% isopropyl alcohol, and then after that I used the microsuction, and you saw the rest. Now these are sterile paper points, and I'm drawing the canals further with sterile paper points. All right, distal buccal. Distal lingual. This is another way of confirming whether the canals join or not. As you can see, they join. The other paper point didn't go to working length because the other one was at working length. You can see that I've already troughed for the middle mesial. You can see the trough between the mesiobuccal and mesiolingual canals right there. All right, so I'm introducing sealer now with sterile paper points, just coating the canal walls with AH+ sealer. That's my sealer. And people always ask me what kind of sealer I use. I only have one kind of sealer. How many kinds of sealer do we need? I only use AH+ sealer. If I don't use AH+ sealer, then that means that I'm using MTA plug. And then I coat if I have to obturate the rest of the canal with gutta-percha, then I coat the canal walls, the remainder of the canal wall, with AH+ sealer, and then I use the injection technique of gutta-percha to fill the rest of the canal. But I only have AH+ sealer, so it's not like for for a special case, specific case, I use a specific kind of sealer. No, I only have AH+ sealer. That's the only sealer I use. And again, it's my preference. If you like some other kind of sealer, by all means, sealer, brand, name, chemistry has not linked to a higher success rate. So don't focus on sealer and all of that stuff. Instead, focus on your irrigation protocol. Focus on that irrigation and activation with 6% sodium hypochlorite copiously throughout. That's more important. It's more important, like I always say, it's more important what you take out of a canal than what you put in to a canal. All right, so these canals join, right? So I decided to put the mesial canals join. So I decided to put a custom gutta-percha master cone in the mesiolingual canal. And now I'm filling the mesiobuccal canal with my obtura gun and using the injection technique. So this is a modified warm vertical obturation technique, modified by me. This is a technique that I sometimes utilize. All right, very good. All right, so let's use our system B and cut that master gutta-percha cone. And my assistant removed the remainder. All right, let's go ahead and condense the gutta-percha apically. I'm using the Buchanan number 2 plugger condenser. Putting apical pressure on the thermoplasticized gutta-percha and keeping the pressure on it for a few seconds, because the thermoplasticized gutta-percha wants to expand as it cools, but you got the apical pressure on it, so it can't expand chronally because you have the condenser on it. So instead, it expands apically and laterally. And that's how you obturate all of those complexities that you see on my radiographs, post-op radiographs, all those lateral canals that I have been able to obturate, and all those complexities that I have been able to obturate. And I apologize. I think I mistakenly said that I obturated the mesiobuccal and mesiolingual canal the way I told you I obturated. No, it was actually the distals that I obturated. So I placed the gutta-percha cone in the distal, master gutta-percha cone in the distal lingual canal, and then I used the injection technique to obturate the distal buccal canal. And now I'm using my custom gutta-percha master cones to obturate the 2 mesial canals. So I have the master gutta-percha cone in the mesiobuccal canal, and I'm putting another one in the mesiolingual canal. All right, so let's go ahead and cut with system B and thermoplasticize the gutta-percha, and then Buchanan number 2 plugger, apical pressure, hold it for a few seconds. Do the same thing with the mesiolingual, apical pressure, and hold it for a few seconds. All right. Very good. And then I'm going to use my obtura gun to obturate the rest of the canals, the coronal part of the canals. And you know the rest. I'll be using a cotton pellet soaked in 70% isopropyl alcohol to clean the pulp chamber. remove the extra sealer and then dry the pulp chamber, and then I'll be placing a sterile sponge in the pulp chamber, followed by cavet, and then I'll be removing the gutta percha. I'll be removing the rubber dam. I'll be removing the rubber dam. That's the only time that the rubber dam comes off, is when the tooth is sealed coronally. You got a nice coronal seal. All right, so we are done with the endodontic retreatment of this tooth number 30. So as I said, I'm going to clean the pulp chamber with 70% isopropyl alcohol, then dry it, sterile sponge, and cavet goes in, and rubber dam is removed. Very good. All right, so you really don't need to see the rest. All right, so here it is. Cotton pellets soaked in 70% isopropyl alcohol. Clean the pulp chamber. Dry it. You can see how nice and clean everything looks. Sterile sponge goes in for the general dentist, and cavet goes in. My assistant is putting in more cavet. A little bit more. All right, very good. Just make sure I got a good coronal seal. All right, rubber dam is removed. And look, the rubber dam, I removed the rubber dam, the crown came out with the rubber dam. We got lucky. So the crown came out right at the end, and I'm just checking to make sure that my coronal seal is intact, and it is. Remember, I put cavet in there. So there you go. All right, let's go look at the post-op radiographs. This is what we started with. This is the quality of endo that we started with. And now let's go look at the post-op. Here's the post-op. One angulation. All right, so you can see the two distal canals there. You can see that we were able to regain patency in all 4 canal systems. Look at that beautiful anatomy there in the apical area of the distal canals. Let's look at a different angulation. Look at this angulation, guys. By the way, we re-cemented that crown for the patient. So the crown came out, but we re-cemented it. Temporarily, of course. All right, so look at that beautiful anatomy in the apical area. I call it snake tongue. Look at that beautiful anatomy. And let's look at another angulation and look at this angulation. You can see the 2 distal canals. We were able to regain patency in the mesial canals. Look at all of that anastomosis between the mesiobuccal and mesiolingual canals right there. Beautiful anatomy in the apical area of the distal canals. So you can see everything went beautifully. Everything went beautifully, as you can see. So I'm very optimistic about this tooth. I hope this video helped you guys. More videos to come. If I were you, I would watch all of these point of view clinical videos that I've posted 50 times. I remember I used to do that with Dr. Buchanan, Dr. Ruddle's videos. I still watch them sometimes, even to this date. I must have watched Dr. Ruddle's clean shape pack videos like 100 times. So please make sure you subscribe to my channel. Make sure you like, thumbs up, like, and comment. And see you guys in the next video. I hope these videos are helpful for you guys. Practice on extracted teeth. Make sure you practice on extracted teeth. I don't know how many times I should tell you guys this. Practice on extracted teeth. See you guys in the next video. Bye-bye.